Welcome to Developments in the Treatment of Metastatic Triple-Negative Breast Cancer with Dr. Sylvia Adams. My name is Ida Sampaio, Director of Programs at SHARE. Before the presentation begins, I'd like to tell you a bit about SHARE. SHARE is a 40-year-old non-for-profit organization that helps people through breast or ovarian cancer, offering the support of those who've been there. SHARE offers many services, including helplines, telephone and in-person support groups, and educational programs. All services are free of charge to participants. For more information, visit our website at www.sharecancersupport.org. All participants will be muted during the presentation. You are welcome to submit questions throughout the presentation. You can submit questions by typing a question into the question panel on your webinar control panel. When Dr. Adams finishes speaking, we will open up for questions and answers. Questions that have been submitted will be read. This webinar will be recorded and posted on SHARE's website soon. Now, I'd like to introduce our speaker. Dr. Sylvia Adams is a medical oncologist caring for patients with breast cancer. She also has expertise in the development and conduct of cancer immunotherapy trials. Her work has been awarded several grants from the American Society of Clinical Oncology, which is ASCO, and the National Cancer Institute. She has published several original research articles as well as reviews and book chapters on breast cancer and cancer immunotherapy. Dr. Adams received a Master of Science in Clinical Investigation at New York University in 2010 and serves as Vice Chair of the NYU IRB. Welcome, Dr. Adams.
Thank you so much for having me for this webinar. I am very honored to be able to discuss some new treatment options and advances for patients with metastatic triple-negative breast cancer. So you are probably aware of the excitement surrounding checkpoint immune antibodies that have been approved by the Federal Drug Administration over the past few years for several tumors, and these include tumors such as melanoma, skin cancer, lung cancer, and renal cell cancer, as well as bladder cancer. And one of the liquid tumors called Hodgkin's lymphoma. Even yesterday, approval was granted to one of those medicines for patients after first-line treatment for metastatic lung cancer. So this is a very exciting field, and I personally hope and am involved in studies to bring these drugs into breast cancer as well. And I will tell you the expected timeline for FDA approval of these compounds for breast cancer as well later in my presentation. When you look at this slide, you actually see what a pathologist sees under the microscope looking at a triple-negative breast cancer. And looking at this tumor, only these light purple areas or islets are actually tumor cells. The rest, these surrounding areas here, are actually the stroma, which is not tumor cells but supporting soft tissue structures, and infiltrating those structures are lymphocytes. So we call these tumor-infiltrating lymphocytes. And it's very important to know and understand why these immune cells are there and what they are capable of as a rationale for the development of these newer immunotherapies in breast cancer. So a lymphocyte is a patient's own or a person's own immune cell that is capable of finding a tumor cell or a virus or another invader and destroying that, killing that cell. And therefore, these cells, these lymphocytes, are called cytotoxic T cells because they have the capability to completely destroy the cell that is infected with a virus or a cancer cell once it recognizes it. And the exciting discovery that we contributed to this field is shown in this picture, that at diagnosis, so when a woman undergoes breast surgery first for early cancer, one can find in the tumors of most women lymphocytes, meaning that the immune system has already seen the tumor cells and has tried to attack them. And just a little overview of how the immune response against cancer works is shown in this cartoon. So you go from left to right. In the left, you see the area of a tumor, with the green, light green being tumor cells that are malignant cancer cells that need to be destructed by the immune system, and in darker green with dendrites are the body's own dendritic cells. And they're very potent in picking up pieces of tumors and showing them to a person's immune system. So when those dendritic cells do pick up these tumor pieces here, and little antigens that are presented on the tumors, they can then travel into the draining lymph node, go into the lymph node, and here present these tumor particles to our immune cells or lymphocytes. And there's two main types, CD4 and CD8 cells, and while both are important, these CD8 cells are the T cells or lymphocytes that can kill, as I mentioned, the killer T cells or lymphocytes. So once these cells are primed and know what to look out for, and that is these small tumor particles, they can actually leave the lymph node, go back into the circulation, and traffic into the tumor bed again. In here, when they are functional, they can kill tumor cells. As you can see here, the membrane of the cell is already disintegrated, and this cancer cell is being killed. However, there are some mechanisms by which tumors bring up shields to prevent these T cells to attack them. And we will talk about those later. They are called PD-1 and PD-L1. And this is a target for the new immunotherapies that we have now to enable an effective killing of the tumor. So now, after knowing this, you can see that these lymphocytes that are all in here, there are more lymphocytes than cancer cells in this slide. This represents the fact that already this priming and T cell trafficking has occurred, and the cells are ready to fight in the tumor. So this is an important finding for breast cancers. And while I showed you a slide of triple-negative tumors, it actually matters what subtype of breast cancer the patient has. So you may know the hormone receptor positive tumors are the majority of breast cancers. We actually divide them into luminal A and B tumors. Then there is the HER2 enriched tumors, and then there is basal-like or triple-negative tumors, which is what we are talking about today. And in this subtype of triple-negative tumors, the incidence of lymphocytes found in the tumor is very high, and actually the highest among all these tumors. And importantly, we have shown that it matters for the patient's survival. So in this slide, I will walk you through this very busy slide, but this is an important study to know. So we actually worked with a cooperative cancer group in the United States called ECOG in Akron, and pulled slides from 500 women who had triple-negative breast cancers that were treated on a clinical large trial of adjuvant therapy with a standard anthracycline and taxane 10 years ago. And we looked at those samples and had two pathologists grade the degree of lymphocyte infiltration in the tumor. And here you see an example of a breast cancer, triple negative, which has no lymphocytes in it. And then in contrast, you have a cancer here that is completely replaced by a brisk infiltrate of these lymphocytes. And importantly, when you look at the outcome, all patients got the same treatment. They got chemotherapy, but patients who had these very brisk infiltrates in their tumor had an excellent outcome, whereas patients without TILs in their tumors had often relapses and died of their cancer. So this is a very important discovery, because for every 10% increase in these lymphocytes in the tumor at diagnosis, women had a 19% better chance of survival. And our study, which is shown here, which is the ECOG trial, which was in 500 patients, and included patients with lymph node negative disease and positive disease, and this is what I mentioned to you, has a very strong impact on overall survival when you have more lymphocytes. This study was basically confirmed by two European studies, BIG, which had over 2,000 patients, of which 200 were triple negative, and a Finnish study that had 100 patients with triple negative disease, as well as a French study with 200 patients. All of these trials showed that there is a significant impact on the outcome for the patient, depending on the patient's own immune response to the tumor that is already there at diagnosis. So what does that mean for you and for us? In 80% of patients with triple negative breast cancer, we saw these TILs. So 80% of tumors can be considered immunogenic. And 10% of those actually have more lymphocytes than tumor cells, which we call now this new subtype of lymphocyte predominant breast cancer. And what does it mean? It means that these TILs show that our body already has established a true T-cell immune response, which then, as we saw, is linked to patient survival. So we, in international collaboration with several pathologists and oncologists across the world, established guidelines to be able to enumerate these TILs in breast cancer so they can be used for clinical studies, for instance. But most importantly, this information is important because it shows that the immune response actually can change survival for the patient. And we have strong optimism that targeting and harnessing the immune system can actually help us cure more patients with triple negative disease. So bringing it back to the T cells that are in the tumors, these lymphocytes, and I mentioned to you early on the PD-1 and PD-L1 as mechanisms the tumors actually upregulate to dampen that immune response. And in this cartoon, you have the killer T cell trying to attack a cancer cell. But what happens is that both cells upregulate receptors, the cancer cell PD-L1, the tumor cell PD-1, that exhaust this T cell and make it non-functional and protect this cancer cell from the attack of the killer cell. So if you use a drug, which is, we call these immune checkpoint blockade drugs, they are mostly antibodies. The ones on the list initially I showed you that are FDA approved for other tumors. So these drugs can actually bind to these receptors here and block that negative feedback loop. And what that does is that it blocks the inhibitory pathways, which are PD-1 in the T cells and PD-L1 on the cancer cell, and it restores the activity of this killer cell. And now, when you block this negative piece, you can actually kill the cancer cell with the T cells that are already present in the tumor and are ready to kill, except they were up against a shield, which is now taken down by this immune drug. So for breast cancer in the metastatic setting, we have 2 studies now that have been presented that one study uses a PD-1 inhibitor antibody, the other one uses an anti-PD-L1 antibody, and both are working on the same pathway. They both reinvigorate T cells to kill tumors. And those studies are important for a couple of reasons. You can see here the number of patients is in the 20 to 30 range, but importantly, those patients had already been through many treatments with chemotherapy, as there's no other targeted therapy for triple-negative breast cancer. And they were selected. The tumors were actually examined by pathologists, and they were selected to be expressing the PD-L1 on the tumor cells. So these were selected patients. And how often did that happen? So in the first study, about half of the patients that were screened had the PD-L1 expression. In the second study, about a quarter of patients had this expression. Regardless, the response, which is defined as tumor shrinkage, either by 50% shrinkage or complete remission, was seen in 18% in the left study and 19% in the right study. But more importantly, it is not only that we are able to induce tumor shrinkage, which is something that chemotherapy can also do, but as in other cancers, the exciting piece here is that the responses, at least some of those responses, are actually durable. So when you look at this time graph here for this study, these are patients' tumor sizes starting out at 0. So for instance, a patient who has a 10 centimeter tumor is neutralized to 0. If it grows, it goes up. If it actually shrinks, it is on the downslope. So everyone meeting this or going below this dashed line is a responder by criteria that we use when we look at scans from patients. So you can see that not all patients had a response, but a significant number. And importantly, look at this time of the duration of the response. So there were several women that close to 1 year into treatment actually still had control of their breast cancer that did not grow. And that is really, really exciting because with chemotherapy, this is rarely achievable. The other study had very similar findings. Here again, you have this plot where you have tumor reduction below the 30% range here. And some patients had a long time on study with prolonged control of their cancer. So I run this study globally. This is a study using this, the first column I showed you, the Pembrolizumab, which is an anti-PD-1 antibody for women and men who have metastatic triple-negative breast cancer. It is done in 2 arms. In the first-line setting, so women just diagnosed with metastatic cancer, this drug is given on its own if the tumor expresses PD-L1, and we discussed it in about 50% of patients. In subsequent lines, so after women already received chemotherapy for metastatic disease, those tumors do not have to express the PD-L1 target. The study endpoints are survival this is called overall survival, and certainly responses and how long those responses last. And because this drug has had such potent efficacy, we actually have now a study that is soon opening up where this drug will be used earlier on breast cancer for women who have received chemotherapy before their breast surgery, but have at the breast surgery time still have tumor left. And we know that once tumors still found after standard chemotherapy, then the outcome for women is not as good as if they were to have a complete resolution of their cancer. So those women now will be eligible for this upcoming study run by SWOG, one of the cooperative groups in this country, and there will be a randomization to the PD-1 inhibitor versus observation. And from this study, we will learn if even early on when we treat women, we will be able to improve cure rates. But back to the metastatic setting, because this is the topic of today's talk. So the reason, actually I'm going to the next slide. So the reason why we use combination therapies with immunotherapy is to improve on the numbers, on the cure or on the long-term improvement numbers. So I showed you single agents. Those drugs probably have a response in about 19% of patients. But if you add chemotherapy to it, you can hopefully bring it up to the 40 or 50% range. So why do we use chemotherapy in combination? One is that it allows us to actually keep patients stable, because some patients have very aggressive tumors and progress rapidly, and therefore we are able to allow time for the immune therapy to work. Also, in mouse models, certainly there has been synergy shown for those two modalities to work well together. We know that the drug that we are using, Nab-paclitaxel, has some immune stimulating effects. Usually people thought that chemotherapy is very immunosuppressive. However, there are some components of chemotherapy that actually can help us. They can destroy the immunosuppressive cells, or they can just make cancer cells more visible by killing some of those cancer cells. And in addition, we chose Nab-paclitaxel or Abraxane as the partner for this combination because it is FDA approved already, and we don't have to use steroids, which may decrease the immune response. So for this study, patients were eligible if they had either no treatment in the metastatic disease setting or up to 2 prior lines of chemotherapy. And we gave women Nab-paclitaxel, which was given, you all know these sequences, day 1, 8, and 15 every 4 months, and the anti-PD-L1 drug, atezolizumab, we gave that every 2 weeks. The study was an early study, so it was a phase 1 study looking at safety and tolerability, but we did also look at the response rate. And we also had access to biopsies from tumors to really look at the lymphocytes in the tumors and how they change with treatment to be able to design better therapies even. So here is the safety data. We enrolled 32 patients, and I presented this data at ASCO, so this is publicly available. Out of those 32 patients, they all received 1 dose of the antibodies so far, and therefore we could talk about safety data. There was no unusual toxicity. As we know, immunotherapy has distinct side effects. It can cause autoimmune problems in a subgroup of patients, and this is what we confirmed here. There was 1 patient who had new onset diabetes. There was 1 patient with liver function abnormalities. Those were the typical autoimmune treatment-related effects, but we also saw changes in the thyroid function profile. In terms of the efficacy, again, this is a phase 1 trial, and the results are preliminary because of that, but we saw in the first-line setting, so patients who were just diagnosed or did not have any chemotherapy for stage 4 disease, we saw a very high response rate. And if you combine patients from the first, second, and third line treatment, we still saw a very encouraging number. And when you look at those plots again of the tumor volume and its reduction, what you can see is that in each of those lines, you have patients with prolonged responses. So we at NYU actually currently have 2 patients that have been on treatment for over 2 years. And they actually were able to stop, because of excellent tumor control, they were able to stop the chemotherapy. But they continue to be without active disease on scans. What is very encouraging is that we don't yet have reached the survival endpoint, which is hopefully meaning that women live longer with this treatment. And I'm going to show you the design of this study that is now ongoing in this country. I just briefly wanted to mention that the level of lymphocytes in the tumor, which is shown here, correlates somewhat with response. So women whose tumor already had lots of lymphocytes in it are depicted here in the green bars, whereas patients who did not have a response but rather had tumor growth on treatment had lower levels of lymphocytes. But we are currently looking at other markers for predictive efficacy. And an interesting actually finding was that women had responses despite PD-L1 expression in their tumor. And that is probably because we are trying with this combination therapy to have a larger group of women get benefit from these drugs. So this is a patient of mine who I mentioned is still ongoing on just the immune drug 2 years later and is off chemotherapy completely. And what you can actually see here is a complete disappearance of these lung tumors and lymph nodes. And this schema also shows one quite infrequent but important way that these immune drugs work. They can stimulate the immune response so significantly that actually one can have new tumors and swellings in other areas after the initial treatment. So while this woman had complete disappearance in the blue areas, she actually had new spots in lymph nodes and in the spleen. However, when you continue treatment, which is not what we do with chemo, for instance, but with immunotherapy, you typically continue. And with 2 more cycles, all of these new spots are gone as well. And this is the ongoing phase 3 study that I'm part of the global steering committee for this trial. It is a study that is targeting women, or that is used for women who just had metastatic disease without any prior treatments. About 900 patients will be enrolled, and this is done worldwide. And patients get randomized to the backbone chemotherapy of Abraxane, and half of the women get the antibody PD-L1 versus the placebo antibody for the other group. And importantly, we will have 2 endpoints, not just how long can this treatment control the tumor, but how can we move survival to make that longer for women. There's many other endpoints, and it is hoped that this will be one of the FDA-approved drugs in the future for breast cancer. In terms of the timelines for FDA approval, these are just predictions by the economists in this country, so this is not an academic slide, but just to give you an idea, the 2 companies that have their drugs in the furthest development in breast cancer are Merck with the anti-PD-1 drug Pembrolizumab, and Roche Genentech with their anti-PD-L1 drug, which is called atezolizumab. And those 2 are expected to have a readout and results next year for the second-line setting, and 1 year after for the first-line setting of triple-negative metastatic disease breast cancer. So it is my great hope that in the next 2 years we will have these drugs on the market based on scientific data from randomized phase 3 studies showing superiority. Now, at NYU, we currently have 1 trial that builds on my prior work in this field, and this is open to accrual, so I will present the eligibility to you. in case you have friends or know of somebody who has metastatic cancer. So this study is for women who have either no prior treatment or up to 2 lines of chemotherapy for metastatic breast cancer. And our goal is to enroll 30 patients who have triple-negative breast cancer and 20 patients who have hormone receptor-positive tumors that are HER2 negative. And this is important that we actually have the subgroup because the definition for triple-negative breast cancers have changed over the last 5 years. Initially, we called receptors negative if estrogen and progesterone were under 10% of cells staining. However, those guidelines have changed to now less than 1% of cell staining. So a woman who ends up having no estrogen receptors, but maybe 3% of progesterone receptors, and it's really truly a triple-negative cancer, those women cannot get access to several of the trials because officially she does not meet the criterion for triple-negative breast cancer, but she would be able to go onto the study into our hormone-positive cohort. It's a one-arm study, so all patients receive the combination therapy. We start with the first cycle of Abraxane given on day 1 and day 8 every 3 weeks, and we add with the second cycle Pembrolizumab, which is the anti-PD-1 drug, and give that every 3 weeks. To be eligible for the study, women must have measurable disease, meaning either on the skin or on scans, tumors that usually are greater than 1 centimeter, and if it involves only lymph nodes, then the smaller diameter has to be over 1.5 centimeters. Because we are still learning much about these treatments and need to be sure how to harness the immune response at its best, we are performing serial biopsies. So women have their baseline biopsies, usually for diagnosis, and then we biopsy after 1 cycle of chemotherapy alone and 1 more biopsy after the combination therapy. Again, as I mentioned, patients can have had up to 2 prior chemotherapy lines, but not a taxane in the last 3 months because it contains a taxane therapy. So patients have to not have that recently. We allow patients who have brain metastases who have been treated for that. So a follow-up scan 4 weeks later should be stable, and there should not be a need for steroid therapy. Pneumonitis, which is an inflammation in the lung, any history of that is actually an exclusion criteria because there is safety concerns of this drug in women who had pneumonitis. And I want to also encourage women who have a very rare breast cancer type called metaplastic breast cancer, which is triple negative, but it's really only 1% of those tumors, and extremely rare. I would encourage those women to specifically seek out the study and come forward because we have seen a really dramatic response in the subtype, this is really truly a revolutionary finding because there is no other treatments, not even chemotherapy, that helps in metaplastic breast cancers. So the endpoints for the study are in the first 2 patients, the safety of the combination. So far, there's no issues, and then the response in the group of patients with triple-negative cancer. We're also looking at survival and the biomarkers to predict for the future which women will benefit from these treatments. So back to our Immunology 101 schema, we kind of know now what we should do with tumors or with patients who have tumors that are rich in lymphocytes, so where the immune system already has established an immune response, but they have been subsequently attenuated by the tumor. So in those situations, we just take away the negative inhibitory component, and we are able to have dramatic responses that are long-lasting in these patients. But for patients, and I mentioned initially 20% of patients with triple-negative disease do not have lymphocytes in their tumors. What do we do with those women? Because we really want to convert their tumors from these, we call them colds because they don't have lymphocytes, into hot tumors that are rich in lymphocytes. How do we do this so that these women also benefit from immune therapies? And basically what you need to do is you need to stimulate this initial arm of starting an immune response, and that can be done via several different pathways. And the ones we have studied at NYU the most are radiation therapy. So we utilize radiation with very few fractions, for instance, in women with several metastases, and just radiate one metastasis to re-stimulate the immune response, to kill those tumor cells so that dendritic cells can take up those pieces and then start this process. Another way to do this is by using toll-like receptor agonists. And we've published several studies showing that if you use topical or injectable toll-like receptors into the tumor or onto the tumor, like an example is omicromod cream, which is used for melanoma, but it could even be used for breast cancer skin metastases. And we have published that in 2012. In those scenarios, you actually activate dendritic cells to pick up those tumor pieces and get that immune response started. There are certainly many other mechanisms by which we can enhance this process. I listed only a few here on the bottom, and sometimes we also need to help the trafficking back into the tumor because there are some mechanical barriers for lymphocytes to get in. And radiation is one of those areas or one of those approaches that can actually help the trafficking of T cells back into the tumor. So this is just an overview of how we approach the treatments for metastatic triple-negative breast cancer now. And to summarize, I hope I showed you that there is convincing evidence that some breast cancer subtypes are truly immunogenic, and that is true for triple-negative disease, that we have shown that the immune response by virtue of lymphocytes sitting in the tumor is actually prognostic. It impacts the survival for patients. And therefore, we have great hope that we can really turn around survival and treatments for women with triple-negative breast cancer. And I'm not just saying for women who have early disease and maybe helped to be cured by, the study that we talked about using immunotherapy after the surgery if there's still tumor. But I also have this real big hope that we can do this for women who have metastatic triple-negative cancer. And I've seen it in the clinic. I've seen these women who are without treatment living their lives normally without any evidence of cancer. And this is really, truly transforming in this field. And the next point is that we do have several ways to kind of inflame the tumor, to make it hot, and to basically change from non-responsive tumors into responsive tumors. And there are many more studies that are needed, that need to be done, but there is certainly promise in using combination therapy. And lastly, I think it's very promising. I think any woman who has metastatic triple-negative breast cancer should really seek out a study to get into, because chemotherapy itself is not a home run. There is no reports of prolonged tumor control with standard chemotherapy alone, but that is possible with immune therapies. So please encourage your friends to participate in trials. You can find the studies that are open to patients on the website run by the government. And I would also look for combination studies because they hold the premise that you can actually have a higher chance for responses. And look at this. This is amazing. We have so many studies now in every city in this country, and we're making great progress. So I would like to thank you for joining this webinar, and I'm happy to take questions.
Thank you, Dr. Adams. That was very, very interesting. A lot of really good information for women that are dealing with metastatic triple-negative breast cancer. We have a few questions here. One of them is asking you to explain further the synergy between chemotherapy and immunotherapy and how that works.
I'm sorry, could you repeat the question, please?
Sure. They were asking about the synergy of chemotherapy and immunotherapy and how that works.
Actually, let me go back to the, do you still see my slides?
Yes, we can still see them. Thank you.
So this is actually one of the clear answers of why there is such synergy. Number one, as I mentioned before, chemotherapy can keep the woman stable from a very aggressive tumor. So it also shrinks tumors. It is not durable shrinkage, but it does shrink tumors initially. So we use that to lower the tumor burden, and the tumor itself has such immune suppressive function that the less tumor you have, the better off one is for immunotherapy. And then in ways why Taxol, for instance, can actually be helping the immune response, there's several different ways to do that. One is that it brings up signals on the tumor cell to be recognized by the immune system. And then it also takes away and kills suppressor T cells that make our lymphocytes weaker. And it also reduces other immune suppressive mechanisms and cells in the tumors. And furthermore, chemotherapy, and this is what we're investigating actively, is able to increase the expression of the target PD-L1 on the tumor cells. So there are several mechanisms by which chemotherapy can help immunotherapy, and the combination is certainly in the clinic better in terms of reaching a response rate. The question remains if the durable responses are also increased when you use the combination over single-agent immunotherapy alone, but only time will give us that answer when we have more follow-up on the studies such as the phase 1 study I presented to you.
Thank you. That sounds really interesting. Someone was asking about what do we know about the autoimmune response and in which specific subgroups?
So the autoimmune toxicity and side effects are truly, they're not predictable for which patient they can happen, but we do see those in probably 20 to 30% of patients. They vary from skin rashes to diarrhea to liver impairment to rare complications such as colitis. And you know, it's very important that you are treated in a center that is familiar with those side effects, and that you communicate well with your physician, because they can be treated if they are found and discovered and treated early. So usually we interrupt treatment and give steroids that really bring this autoimmune problem back to normal in most patients. So it's important to be treated at good centers and also report symptoms early. And one of my colleagues always said that any symptom, any side effects that you have on these drugs is autoimmune until proven otherwise. So you have to have a low threshold to treat, for instance, diarrhea or other side effects for patients.
Thank you. One of our participants had a question regarding the correlation on the lymphocytes, the amounts in patients, if you were able to find out how the amounts were in their early breast cancer then compared to their metastasis. Was there any correlation there?
Yeah, that's a very important question. And actually, we are planning with different centers around the country to answer that question. Right now, it's limited information when you look at tumors from the same woman at the when you look at the primary tumor and then the subsequent tumors. From my own experience in women that I've treated, it is usually somewhat reduced in the metastases, but it's still present. And again, we will perform a study where we look at these paired samples and see if the lymphocyte magnitude goes up or down, but probably somewhat down over time, but I think still present, and we still need more data on metastatic tumors because most of the information that we have right now for breast cancer and TILs is in the early settings because patients have the surgery and those tissues are accessible. For patients who have metastatic disease, it is often harder to obtain tissues, but we will find this out in the next year or so.
Oh, that's great. That's great. Someone was asking what kind of symptoms and screenings should a survivor of triple-negative breast cancer have?
So that means a woman who has completed all primary treatment and does not have any evidence of cancer at this time?
Right.
I assume, okay. So, many women want scans and markers, but the opinion across, professional organizations such as ASCO and the guidelines actually argue against that because that those tests can be falsely positive and falsely negative. So the current way to follow women is really closely pay attention to symptoms. If there's any new symptom that a woman reports, especially cough or bone pain that persists for more than a month or two, that should be investigated. But there is no recommended standard screening by blood tests or imaging because what happens often is you find something that is not even cancer, and women have to undergo multiple biopsies and scares, etc. So the consensus is not to do this routinely, but you should have routine follow-ups with your oncologist. I recommend usually in the first 3 years to see your oncologist every 4 months, and then years 4 to 5 every 6 months, and then afterwards annually.
Thank you. And one of the things is with triple-negative breast cancer that it's very aggressive, and in many cases it affects younger women, including many women who are African American or Latinas. So are within the studies that are being done, are they making sure that they're bringing enough diverse patients? We are certainly open for any ethnicity. There's no restriction on that at all. And if patients speak different languages, we are accommodating that with either translated consent forms or in-person translators. So we are open to that, but certainly it is also a question of how well you're able to reach out to them and make them aware of these findings. And I hope that through SHARE, because you have such different language parts in your organization, that you're able to actually reach the Spanish and Asian communities more effectively. Yes, we are working on that. We're working on making sure that women have the information, and we also have a patient navigator over at Bellevue.
Yes.
Who translates the information too, so
yes,
Maria. So.
I know her.
Okay, so the last question is a little different, and I'm not sure if this would actually be the best question right now, but it's the last one that I have. It's numerous large international studies have recently confirmed that lobular is a distinct disease. I'm interested in exploring the therapeutic landscape of immunotherapies for the extremely rare cohort of NTNBC for ILC. I am not sure.
NP, I don't know what that NP stands
well,
for.
I guess maybe it might be that the M may be metastatic triple-negative breast cancer in patients with lobular. ILC.
So the data the data is very scanned on treatments with immunotherapy on that, and that's why we're encouraging women to participate in this study, including ours is one of the only few studies that allows women who have hormone-positive cancer to join. But there was recent studies, as the person asked. There is recent studies showing the genomic profiling of these lobular cancers. There's also a study that showed exactly how many lymphocytes are found in those tumors. we do not yet have evidence that the amount of lymphocytes in hormone-positive tumors correlates with outcome. So that diminishes somewhat the enthusiasm for checkpoint drugs. But I think there will be several other mechanisms by which these tumors can be treated. So I again would think there is trial opportunities out there that one can look for.
Thank you. So I'd like to thank Dr. Sylvia Adams for an informative program, and I'd like to thank all the participants. Please take a moment to fill out the survey at the end of this webinar. And once again, Dr. Adams, thank you so much for all this important information that you've been able to provide. And I want to remind everyone that Cher will be posting this recording on our website soon. Thank you, everyone.
Well, thank you very much for having me.